Hello, in this episode we discuss neck infections. I have categorized these conditions together as they belong to the soft tissue infection, while I would focus on discussion of those conditions directly affecting the upper respiratory tract and pharynx, such as epiglottitis, croup, tracheitis, diphtheria, in a different episode. Also, most of these conditions originate from an initial septic focus, be it pharyngotonsillitis or a sinusitis, ear infection, mastoiditis, or conditions associated with dental infection or procedures that complicate to some of these conditions. And furthermore, many of these conditions could complicate into more serious infective or thrombotic comorbidities. And based on that, I thought understanding of an anatomic diagram of the connections between different deep neck spaces could be helpful. So just a quick overview. You see around this region in this yellow marked space, this is just our visceral space containing upper respiratory tract elements, and it is surrounded by the middle layer of deep cervical fascia. Just posterior to that, we have this area that's marked in green. If you can see it here, this area designates the important retropharyngeal space. Okay, I would like us to understand that these spaces are continuous. For example, this retropharyngeal space goes to superior mediastinum. Understanding of this continuity would help us understand why retropharyngeal abscess may complicate into necrotizing mediastinitis or even empyema. This retropharyngeal space itself is separated by a region or space behind it, posterior to it, that's referred to as danger space. That's a space in which any infection can have easy access to several spaces. This line that I just drew designates the alar fascia separating the retropharyngeal space from the danger space, just posterior to that retropharyngeal space, as you can see. And we have another important space here posteriorly around the spinal column and all these muscles around it. This is called the prevertebral space, surrounded by this prevertebral fascia. And again, infections of the deep neck spaces could reach this area, though it's not very common. However, it's important to know that, for example, a differential diagnosis of deep neck infections is the prevertebral cellulitis, and that is why we perform CT to rule out prevertebral cellulitis. And finally, here in the lateral part, you can see we have the parapharyngeal or lateral pharyngeal space, very important space containing the carotid space on it with the carotid sheath. So we have the internal jugular vein, posterolateral to the internal carotid artery. These two are important to remember because many of these conditions can complicate into septic thrombi into these vessels and cause, for example, thrombophlebitis of internal jugular vein, that is Lemierre's disease. So if you have a good understanding of this pretty simple diagram, we are ready to go and start our discussion. Again, anterior is here. We have the retropharyngeal space with the danger space. We have this prevertebral space, and we have the lateral pharyngeal space or parapharyngeal space with carotid and internal jugular vein. That's all. With that background, we turn our attention to discussion of individual neck infections, beginning with retropharyngeal abscess. First question: what are the common symptoms between retropharyngeal and peritonsillar abscess? Both conditions are associated with fever, sore throat, drooling, hot potato or muffled voice, and trismus. Both conditions are also unilateral and associated with cervical lymphadenopathy. Again, most commonly unilateral. Next question is, what are the common pathogens for both conditions? Group A, Streptococcus, is the most common, followed by Staphylococcus aureus and oral anaerobes. Usually, retropharyngeal abscess is said to be a polymicrobial condition. So what clinical features help differentiate retropharyngeal abscess? First and foremost, remember that it is common in kids age 6 months to 6 years. It is not very common after age 6, while peritonsillar abscess happens in teenage kids, that's in kids older than 10 years. Other than that, retropharyngeal abscess is usually a more toxic kid with high fever, abrupt onset of symptoms, and the patient obtains a specific position with neck extension, and he prefers to lie supine. Do you remember another neck infectious condition in which patient prefers to extend the neck? That is the tripod position seen in epiglottitis. However, in epiglottitis, the patient, as indicated by the name tripod, does not lie back. The patient sits up. This neck extension is an attempt to open up the upper airway. Based on this, if you are asked what can worsen the symptoms in retropharyngeal abscess, remember sitting up or flexing the neck. These worsen the symptom. Describe 2 important physical exam findings in retropharyngeal abscess. Neck is not supple. The patient holds the neck in extended position, so it may confuse, given its high fever, with the meningitis. Also, if pharyngoscopy is attempted, we may see a mass in the posterior pharyngeal wall. What is the diagnostic workup for patient with retropharyngeal abscess? The most important finding is increased thickness of retropharyngeal soft tissue. There's a reference for that, and that is the soft tissue in the retropharyngeal space should be less than half of the diameter of corresponding vertebral body. If it's more than that, it indicates an abscess in the retropharyngeal space. If you remember our picture, I mentioned an important condition needs to be ruled out in this situation. And what is it? That is prevertebral abscess should be ruled out. And what is the test for that? The test is cervical CT scan. Of course, we are looking for an abscess, so we need a contrast CT study. What's the treatment for retropharyngeal abscess? Either needle aspiration or incision and drainage, followed by antibiotics. Now, what is the most important factor in choice of antibiotic? The origin of the infection. Another factor is if we deal with immunocompetent or immunocompromised patient. So let me give you some examples. If the patient is immunocompetent and retropharyngeal abscess ensued a dental infection or any type of oral infection, what pathogens should be covered? Streptococcus viridans, the famous oral pathogen, as well as oral anaerobes. For strep viridans, we can use ampicillin sulbactam, and for the anaerobes, we can use cefepime or a fluoroquinolone such as ciprofloxacin, or we can use the famous drug for anaerobes, that's metronidazole. Now, very important question. If retropharyngeal abscess happens as a complication of dental procedure, dental infection, dental abscess, or oral infection, and the patient is penicillin allergic, true or false? The best alternative for penicillin allergic patients is, as usual, clindamycin. While we say ampicillin sulbactam is the overall treatment modality, antibiotic of choice, and if patient is penicillin allergic, we use clindamycin. The very important exception is the case of patient who had the neck infection, such as retropharyngeal abscess, as a complication of dental procedure or oral infection. In this case, we are dealing with the Streptococcus viridans, as I mentioned, right? Always remember, strep viridans is resistant to clindamycin, so we need to pick any of the other drugs that I mentioned. Now, another important question regarding the oral infection is, do we need to cover any gram negatives? Unfortunately, that is a big yes, and we do need to cover them. We usually use piperacillin tazobactam for that, pip-tazo. What pathogens should be covered in immunocompromised patients with deep neck infection? We are thinking about resistant pathogens. Always remember the immunodeficiency state is a risk factor for both MRSA and Pseudomonas. So we need to cover MRSA with Vanco and the possibility or risk of Pseudomonas with piperacillin tazobactam, pip-tazo. Another scenario is you have had a patient with dental infection who came with the symptoms of retropharyngeal abscess, and you initiated the treatment. After a couple weeks, the patient comes with altered mental status and shock to emergency department, and chest x-ray shows widened mediastinum. Now, what is the antibiotic treatment for this patient? Remember again, I mentioned the possibility of spread of infection from the retropharyngeal space downward to superior mediastinum, causing necrotizing mediastinitis. This requires surgical debridement and broad spectrum antibiotic coverage for at least 2 to 6 weeks. Okay, moving to peritonsillar abscess. So once more, what are the signs, symptoms specifically that helps differentiate it from retropharyngeal abscess? While we again have sore throat and muffled voice or hot potato voice, trismus, drooling, and lymphadenopathy with fever, first and foremost, the fever is not very high, the child is not very toxic, and the important physical exam finding is deviation or displacement of the uvula to the opposite side, because the abscess is pushing the uvula to the opposite side. Also, the patient does not have any specific or preferred positioning for the neck. Neck is also supple, so we do not have the held extension position or stiffness of the neck in the case of peritonsillar abscess. Now, you might hear this term Quinsy abscess. This is a variant of peritonsillar abscess when it is a complication of pharyngitis and when it is usually mediated by, therefore, mixed oral flora. True or false, an important feature to differentiate peritonsillar from retropharyngeal abscess is absence of trismus in peritonsillar abscess. That's false. Both retropharyngeal and peritonsillar abscess could have trismus. You know, that spasm of jaw muscles that can limit the physical exam. Now, let's review the best versus first tests in peritonsillar and retropharyngeal abscess once more. We mentioned the very first test in the case of retropharyngeal abscess is the lateral neck x-ray that shows increased retropharyngeal soft tissue, and we mentioned the best test is the contrast CT, given the fact that we needed to differentiate that from the perivertebral abscess. In the case of peritonsillar abscess, the very first and best tests are both the same, and that's intraoral or submandibular ultrasound. Now, treatment is again antibiotics with incision and drainage. However, I would like to go a bit deeper on that. When we use the needle aspiration and when we use incision and drainage. Remember that if the patient is an adult cooperative patient, we usually can do an ultrasound guided needle aspiration instead of incision and drainage. However, if we are dealing with children or if we are having an uncooperative adult, we need to go on with incision and drainage. The antibiotic coverage is the same. We use ampicillin sulbactam for around 2 weeks. If patient is penicillin allergic, we use clindamycin, again for peritonsillar abscess. Final important question is when tonsillectomy is indicated. Always remember, if you are dealing with recurrent peritonsillar abscess or recurrent pharyngitis. Now, what are the possible complications of these deep neck infections and abscesses? One is carotid rupture, the other is mediastinitis or sepsis. We can also have possibility of airway obstruction and internal jugular venous thrombosis. Now, we mentioned the possibility of airway obstruction as a complication of deep neck abscesses. Now, do the patients without this complication usually have a stridor? No. Remember, stridor is not a common finding in uncomplicated retropharyngeal or peritonsillar abscess. This helps distinguish it from epiglottitis, but we'll discuss epiglottitis, croup, tracheitis, diphtheria in a separate episode. For now, remember, these abscesses, if not complicated and not posing any airway obstruction, they are not associated with stridor. Okay, now moving to one of these complications, which is Lemierre's disease. What is it? It's internal jugular vein thrombophlebitis due to lateral spread of neck infection, and it is mediated by a dental Normoflora Fusobacterium necrophorum. However, mastoiditis could be also an underlying etiology. Now, what are the symptoms of Lemierre's disease? Again, we have dysphagia, neck pain, drooling, and in this specific case, we are dealing with a very toxic patient with very high fever, and specifically we have sternocleidomastoid muscle edema and swelling. What's the workup and management for Lemierre's disease? It's again diagnosed by ultrasound, and after stabilization, we use IV antibiotics. Please always commit this picture to memory that we had a patient with pharyngitis, tonsillitis, mastoiditis, any dental procedure or infection, who now has come with very high fever and swelling of the SCM muscle. This is Lemierre's disease. You need to perform ultrasound for assessment of internal jugular vein. Now, if in the above case they are asked you the patient has contracted the signs symptoms of respiratory distress and O2 sat is dropping, and you have presentation of acute respiratory distress syndrome, and they are asking you what is the mechanism. Remember, the mechanism of ARDS complicating Lemierre's disease is septic pulmonary emboli. So I'm trying not to miss any of the high yield points here, but it's time to move to a couple anginas of the neck and jaw pain. We are not going to discuss Vincent angina or Vincent angina here. We discuss the Ludwig's angina. What is Ludwig's angina? It is a fulminant and bilateral cellulitis of sublingual and submandibular spaces. What is the most common underlying etiology or risk factor? It's most commonly originating from second or third molar extraction as a complication of this procedure. What are the history and physical findings? Painful or difficulty swallowing, that's adenophagia versus dysphagia, as well as drooling, but most importantly, you have this woody or very hard sublingual submandibular edema on physical exam. You literally need to put your hand inside the mouth and really examine the texture of the sublingual and submandibular area. I remember I once examined a patient with Ludwig's angina. It was not a very common thing to see in ED. Again, don't confuse Ludwig's angina with Vincent angina, which is a diagnosis of oral ulcer, which is a ulcerative gingivitis. We have just two more to go. One is cervical lymphadenitis. So what's the best way to differentiate etiologies of cervical lymphadenitis? The rapidly enlarging lymph node with possible erythema and systemic features, possible fever. Think of it in terms of acute versus chronic and unilateral versus bilateral, and add any other symptoms you have, and this Venn diagram would really help you figure out the underlying etiology. So let's go through some cases and examples. Usually we have this in a unilateral way, and we may or may not have a history of upper respiratory infection. That's a general symptom. If it is bilateral, however, I want you to remember for now that it is going to be viral. Other than that, the rest are the differentials of the unilateral, and at the end we discuss the bilateral. So when do we have the acute onset lymphadenitis? What are the most common pathogens? Always remember, group A strep and Staphylococcus aureus are the most common pathogens for acute unilateral lymphadenitis, and these usually cause suppuration. The non-suppurative acute unilateral is usually But what pathogens? By anaerobes or tularemia, depending on the underlying risk factor. So if the patient has been exposed to contaminated water with rabbit urine or any rabbit products, you think of tularemia. However, if the patient had any oral infection, dental procedures, dental infection, you think the oral anaerobes are the underlying cause of this acute non-suppurative lymphadenitis. Now, what is the recommended treatment? Clindamycin covers all the common pathogens that we discussed, Staph aureus and group A strep, as well as the oral anaerobes. However, it does not cover Streptococcus viridis once more, so we may need to wait for the results of the culture. On the other side, if the clinical picture favors tularemia, always remember an aminoglycoside such as gentamicin is the treatment of choice. Now, if you are dealing with chronic unilateral lymphadenitis, what are the common pathogens? Most common is mycobacteria, and among mycobacteria, non-tubercle mycobacteria, the Mycobacterium avium intracellular and Mycobacterium avium complex in general, are the most common cause of unilateral chronic lymphadenitis. What is the specific age? This usually happens in children age 1 to 5 years. But we have a second important differential diagnosis for the chronic unilateral lymphadenitis, and that is Bartonella, the cat scratch disease. So what's the clue? Well, the patient has a papule at the site of a cat bite or scratch. In this situation, azithromycin is the drug of choice for both pathogens causing unilateral chronic lymphadenitis, both for Mycobacterium avium complex and also for Bartonella. We consider azithromycin. For Bartonella, we can also have doxy or erythromycin. And finally, we have the bilateral lymphadenitis. What are the possible diagnostic considerations? We have viruses, but you usually have two clinical scenarios. One is a patient with red eye and sore throat who has bilateral lymphadenitis, does not have any organomegaly or fatigue, is not necessarily in early adult ages. This is pharyngoconjunctivitis fever of adenovirus. While if you have a patient with subacute or chronic mononucleus-like symptoms, mononucleosis-like symptoms are flu-like symptoms, fatigue, organomegaly, that's hepatosplenomegaly, and lymphadenopathy, as well as possibility of this bilateral cervical lymphadenitis. You are dealing with infectious mono or mononucleosis-like syndrome, such as the one mediated by CMV. Always remember to advise patients to avoid contact sports in this situation. The final neck infection we want to discuss is cervicofacial actinomycosis. So what is the clinical picture in the patient with cervicofacial actinomycosis? You have a patient who have had a kind of facial trauma or dental procedure, and now he or she has a cervical lesion with draining sinus tract being the hallmark. What's the diagnosis and workup? It's diagnosed by FNA, and we also need to obtain samples for culture, but we need to initiate the antibiotic therapy given the risk of the condition, and antibiotic is penicillin. Usually we initiate IV, and then we continue with 2 to 6 months of oral penicillin. If the condition is resistant, we use incision and drainage. So these are our differential diagnosis of common neck infections. Again, remember, if you are dealing with a child who has high fever and keeps the neck in the extended position, and X-ray shows increased retropharyngeal soft tissue, you still need to perform CT to rule out prevertebral abscess in the case of retropharyngeal abscess seen in kids at age 6 months to 6 years. However, if uvula is deviated and the kid is not so toxic, you are dealing with peritonsillar abscess. Diagnosis is clinical but can be confirmed by intraoral ultrasound. If the patient is cooperative adult, you can perform ultrasound guided aspiration. needle aspiration. Otherwise, you use incision and drainage. If you have swelling of the SCM muscle with symptoms of neck infection, you consider ultrasound, even though the best test is still for all of these contrast CT. Ultrasound may show echogenicities in the internal jugular vein. Always remember septic thrombi complication that can cause ARDS and pulmonary embolism in the patients with Lemierre's disease. In Ludwig's angina, remember you may need to consider possibility of airway obstruction, so make sure the patient is stabilized. Categorize lymphadenitis based on acute versus chronic, as well as unilateral or viral, which is bilateral, and identify cervicofacial actinomycosis by draining sinus tracts. At the end, don't forget complications such as mediastinitis, carotid rupture, septic emboli, perivertebral abscess, and jugular vein thrombosis. And this finishes our discussion of neck infections.